Well, good afternoon and welcome, everyone. My name is Allison Mayer-Sachs, and I'm the Director of Community Outreach and Cancer Support Services at the Eisenhower Lucy Curci Cancer Center. As I'm sure you all know, October is Breast Cancer Awareness Month, and we are delighted you are joining us today for this special presentation on current concepts in breast imaging. Before I turn the presentation over to Dr. Sylvan and his team, let's do some quick housekeeping items, shall we? You know, when joining a Zoom webinar, you will be automatically muted and your video turned off. We're going to hold questions until the end of our discussion, and we'll do as best we can to get to all of them. You can type your questions via the Q&A tab, and we will get to them. This discussion is being recorded, and it will be available on both the eisenhowerhealth.org website, that's one word, eisenhowerhealth.org, and the Eisenhower Health YouTube channel, probably within about 2 weeks. If you need further assistance with cancer-related matters, please feel free to call us at our Cancer Support Services line, 760-834-3798, or email. As a matter of fact, feel free to email me. I can be reached at asachs@eisenhowerhealth.org. So now it's my pleasure to introduce the medical director of the Eisenhower Lucy Curci Cancer Center, the Schnizter Novack Breast Center, Dr. Paul Sylvan. Let me tell you a little bit about Dr. Sylvan. He's board certified in internal medicine and radiology, specializing in breast imaging. Dr. Sylvan is a graduate of Cornell University, attended Yale University School of Medicine, and completed residencies in both internal medicine and radiology at Yale New Haven Hospital. And if that isn't impressive enough, he then went on to complete a subspecialty training in body imaging and a visiting fellowship in breast imaging with world-renowned radiologist Dr. Laszlo Tabar in Falun, Sweden. I'll now turn this over to Dr. Sylvan.
Thank you, Allison.
You're welcome.
And I would also like to welcome all of you and thank you for joining us today. I'm going to start off by introducing the rest of our team. We are incredibly fortunate here to have 4 dedicated breast imagers who spend 100% of their time doing breast imaging. So first to my left is Dr. Azadeh Elmi. Dr. Elmi did a 2-year research fellowship at Harvard, Massachusetts General Hospital, then did her radiology residency at the University of Pennsylvania, and then her fellowship at Memorial Sloan Kettering in breast imaging. Dr. Elmi has a joint appointment at UCSD and at Eisenhower. And at UCSD, she's assistant professor of radiology in the breast imaging section. She has a number of research interests, and I'm going to let her describe them to you.
So my main research interest is in contrast-enhanced mammography, MRI, and 3D mammogram. And currently, I'm actually conducting a research project that on that one, I'm focusing on the special patient population that we have here at Eisenhower. As we know, our population here are above the age of average age compared to the nation. And we are trying to see if with mammographic imaging in this patient population, how would be the cancer detection, how we are changing their surveillance, and how we are changing their morbidity and mortality in this patient population. The data from this study will be very valuable in case that we have the data available to come up with new guidelines for the nation to recommend that which kind of a screening would be available in the patients 75 years old and older.
Thank you. And then next is Dr. Stephen Saponaro. Dr. Saponaro went to medical school at Jefferson University Medical College in Philadelphia, then did his residency at Pennsylvania Hospital and his fellowship at Hahnemann in Philadelphia. He has been in practice for 23 years and has been on staff here at Eisenhower since 2016. And of the 4 of us, he has the longest tenure here at the Schnitzer Novack Breast Center. Next to Dr. Saponaro is our newest member of the team, Dr. Kent Thompson. Dr. Thompson went to medical school at UC Irvine and did his residency training and fellowship at Harbor UCLA. He just joined us starting this past month, and we are very fortunate to have him as part of the team. And then finally, Danielle Higgins, the most important member of the team. She's the director of the breast center. Danielle began her training as a X-ray technologist and then a mammographer, subsequently became manager of the Schnitzer Novack Breast Center, and now is director and is really a critical piece in the puzzle for us.
Thank you.
Thank you, Dr. Sylvan. So let's get started. And you know, I really want to start with what we've heard so much about and read about, which is like 3D mammogram. Because, you know, Dr. Sylvan, we think of 3D, we kind of think of going to the movies and those silly 3D glasses. So would you share with us what exactly is a 3D mammogram and why do I want one?
So 3D mammography is also referred to as tomosynthesis. And one of the problems with mammography over the years has been difficulty with overlap of the tissue. So when you do a regular 2D mammogram, there are multiple layers of overlapping structures which make visualization difficult. So 3D mammography is really looking at the breast in 1 millimeter thick slices. And so you basically get much finer detail and eliminate much of that overlap. So it's called 3D, but really what it is, it's more like a CAT scan, like where you're taking slices through the breast at 1 millimeter thickness, and then you can basically look at every millimeter section of the breast. Now, it turns out that in the latest technology that we have, they actually take those 1 millimeter slices, 6 of them together, and combine them using an artificial intelligence program into a single slice, which reduces the number of slices we have to look at without losing any of the information in those 1 millimeter thick slices. So in order for 3D mammography to have been approved, to have been FDA approved, it had to be shown that there were benefits to it. And those benefits are increased cancer detection rate over 2D mammography, as well as fewer callbacks compared with 2D mammography.
Well, and isn't that what we want? The increased ability to find those cancers? That's why we're screening.
Absolutely.
That's amazing. And is this covered by insurance? What do we do?
Most insurances cover it. We do have a fund here that helps to cover that, and I'm going to ask Danielle to talk about that a little bit.
We do have a fund called the 3D Access Fund, and it's all in thanks to one of our wonderful donors, Joe Hilliard, who wanted all women to have access to 3D mammography. While most insurances do cover the 3D, there are some that do not. So all of our screening patients that come through Eisenhower, they are forwarded to this fund, and if their insurance does not cover the 3D, it is covered for their screening mammogram. And we've also opened this up to some of our diagnostic patients as well, whose insurance does not cover it. So if there's a need, we will get it covered for them.
So when we make an appointment, it's something we can ask about.
Yes. That is
Wonderful.
Our schedulers will you can ask the schedulers in the scheduling department, and they will then direct it behind the scenes.
Wonderful. And Joe Hilliard, if you're watching this or any of you know Joe, make sure you say thank you to her, because that's pretty remarkable. Yeah. That's terrific. Thank you. Thank you for sharing that. So let's move on. Thanks, Dr. Sylvan. Dr. Elmi, and we talked about this a little earlier too. I've heard quite a bit about something called, I'm going to read it, contrast enhanced mammography, or CEM. Just what is that and how do we use it?
So contrast enhanced mammography is basically an emerging modality in breast imaging. It utilizes contrast while doing a mammogram. So basically you're gonna combine the benefits that we would get from a contrast similar to MRI, and at the same time we would have really high resolution pictures that we would get typically with mammogram. So what it does, this combination would give the opportunity with the radiologist to look into the breast on the structures on mammogram and also on the tumors if they enhance and they light up on the contrast picture. And if there is any subtle tiny cancer that might have missed, on the regular mammogram, this way the radiologist will be able to pick it up at the earliest stage and the smallest size that's possible.
So who's the best candidate for a CEM? Who gets one?
That's actually a great question. Still, we don't have a definite guideline for that. There are a lot of studies that have been performed in the past 10, 20 years about this kind of a study. They have shown that contrast-enhanced mammography can be performed on anyone who needs MRI. So that will be a patient with new diagnosis of breast cancer, a patient who is undergoing new adjuvant therapy or chemotherapy for breast cancer, a symptomatic patient with breast problem who does not get the answer with regular mammogram and ultrasound, and most importantly, for screening in patients who have dense breasts or have personal history of breast cancer or have some family history of breast cancer, but they don't quite qualify for the high-risk screening to get insurance pay for the MRI. So this kind of lump of patient population that actually would be more than 50% of the patient population actually would benefit quite from this technique.
And it's safe?
Yes, it's definitely safe. So this technique actually got FDA approval in 2011. So now it's been in practice for 10 years. So we use, mammogram. So the radiation safety concerns are similar to mammogram, very small amount of radiation, less than a radiation dose that you would get from a cross-country, flight. And it uses contrast similar to CAT scan. So it's a very safe contrast. And the only concern would be if patient has impaired renal function or allergy to contrast. And if any of these two comes up in their questionnaire, this study cannot be done with them. But otherwise, everyone else can have that kind of a study.
Sounds like a great tool to have
It is.
available to us. That's wonderful. Yeah. Thank you.
And the good news is we have it as Eisenhower, and then we are actually one of the very few centers in the Southern California offering this service.
Really?
I have patients at UCSD that ask for it. We don't have it at UCSD, and I refer them to us here. So that's a very great tool, and we are fortunate to have it.
That's impressive. That is impressive. And I'm a patient in that breast center, so it's doubly impressive. Thank you for telling us that. Dr. Saponaro, hi. Hi. I wanted to ask you a little bit, when we were putting together questions about this, about MRI, and if you'd share with us just the role of MRI in breast imaging.
Yes, Allie, thank you. I'm going to have to read some of these comments, but MRI is one of our most powerful tools that we use in combination with mammography and ultrasound. So patients get a screening mammogram, maybe they'll get an ultrasound, and the MRI can be a very powerful tool to add to those other imaging modalities that we use. So why would we do an MRI? Well, the breast MRI can be used to solve diagnostic problems. Let's say a patient has a distortion on their mammogram and the ultrasound is negative. We're like, well, what is that distortion? We might get an MRI, and that the MRI can give us more information and determine whether or not the patient needs to get a biopsy or not. It's used in terms of following patients who already have breast cancer. We evaluate the tumor size and volume, and then if the patient gets chemotherapy, we can reevaluate the patient and determine whether or not the chemotherapy is working. In some selected patients who are at high risk, determined by genetics or other factors, they can be screened with MRI. So they'll get an MRI every maybe 2 years. It depends on what program they're qualifying for, whatever they applies to them specifically. So we tailor each screening program to the patient. It's not generalized. MRI has even more utilities.
Let me jump in for a minute, Doc. So I think what you're saying too then is not everyone's going to get an MRI. There's a protocol. There's a reason that screening is ordered.
Yes, yes. It's for a subset of patients who are going to benefit from that procedure. It's a procedure that requires the patient to go into an MRI machine. And if you've never been in an MRI machine, it's a little more complicated and involved than just getting a mammogram, and a mammogram's a pretty big ordeal already.
Right.
It's also at this point can be somewhat time consuming. It can take about 40 minutes.
Yeah.
And it requires an injection of contrast called gadolinium. And so all of those factors have to be taken into account before you ask someone to have that procedure. In addition, it's costly. It's almost always covered by insurance, but it's still costly. And we like to take that into account.
So staying in the MRI for a minute, there is something that, and I've heard this term used before for other imaging modalities, something called the 3T MRI. Is that something special or different?
Well, the T stands for the word Tesla, but it has nothing to do with the car.
I knew I was going to ask that. Okay, thanks.
It just refers to the power of the magnet. So MRI is magnetic resonance imaging, and the magnet is in the device and it has a power strength. It's a very, very powerful magnet. So a normal or the usual MRI is 1.5 T, and now commercially available and used in clinical settings, we have 3T, which is double the strength of what we would have. That allows us to scan more quickly. It allows us to scan with higher resolution, and allows us to modify our protocols as well, so that we can get more accurate information. We're very fortunate that Dr. Elmi has volunteered to work on some of those protocols, and they'll be forthcoming. It's not something we are currently applying to our practice, but we will be doing that hopefully by the spring, because it requires a special device called a coil, and that coil is not available to us until the springtime.
Understood.
But other than that, the way we do it is very similar. The patient has to lay on her stomach and get an injection either way, whether it's 1.5 T or 3T. This procedure is basically the same, but the 3T should be quicker and more higher resolution imaging.
Okay. And then putting on my glasses again. What about an abbreviated MRI protocol? We were just talking about protocols. Can we speak to that? I was listening to one of their conversations. That's how I know a little about that.
Yes, well, we are working on a protocol which we can apply with certain criteria. Not everyone's going to get an abbreviated MRI. For some people, it's more beneficial to get a standard MRI protocol. But in a subset of people, we will apply an abbreviated protocol, which is really just the same protocol, only shorter. And that takes into account new equipment, because we're getting another new machine in this building as well. And that will allow us to apply a more abbreviated protocol, which is about 15 minutes versus 40 minutes. So abbreviated just means it's shorter time, but we still get the same information.
So I wonder, and really this is for the panel and anyone to jump in. And can you explain, or would you explain to us, is there a certain step-by-step? Do we get a mammogram first, and then if we see something, then we go to, we haven't talked about ultrasound at all, and I know there's breast ultrasound. How do we do that? We talked about protocols, and for those of us joining us today, obviously we don't, our experts don't just pick something, read something about it and go, I think we're going to use that. There's steps to and reasons we do things. Would any one of you or all of you share a bit with us? Dr. Thompson, you can jump in. What do we do first? Do we always start with mammogram?
First off, we start off with a cup of coffee
There
to
we
wake
go.
us all up, because after a while, we're kind of, we're down on that. But ultrasound is used as an adjuvant to mammograms. Sometimes we're trying to see if something is cystic or solid, and the ultrasound will tell us that right away, and it helps us solve the problem. Another aspect of ultrasound is it's sometimes if we're going to biopsy something, it's much easier to biopsy it under ultrasound. So we'll check and see if the ultrasound can find the abnormality. And if it does, it's much easier to undergo a biopsy with ultrasound. And then with MRI, sometimes an MRI abnormality, we'll check to see if it has an ultrasound correlate. And again, the biopsy is much easier under ultrasound than it would be under these other modalities.
And Allie, I think the most important thing to relay is that we should start with mammography, because mammography is your first screening tool, especially if you're going to be finding those breast cancers the size of a grain of salt. You know, that's where you want to, if you have to have a breast cancer, you want to find it that small. So, you know, I know sometimes there's some misconceptions out there that we don't need to have a mammogram, but you really do need, you know, women need to know that you really do need to start with your mammogram. And also there's another little misconception that we don't have to compress, you know, so we do have to compress your breast, you know, while it has gotten better over the years. You know, I know a lot of women, especially with our new equipment, it's less compression, but mammography and, you know, compressing the breast to see through that dense breast tissue or to see through any of the type of breast tissue is really where you need to start.
And a little compression for something that could possibly save your life. Ladies and gentlemen, I think that sounds worthwhile to me, for sure.
Absolutely,
Thank you.
absolutely.
And then, Dr. Sylvan, would you share a little bit with us about, there's been so much going on upstairs. I have an office just down the hallway from the breast center. There is a lot going on for you guys. What's new there and what's coming down the road?
Sure. Well, first of all, I don't know who's listening, but if any of our donors are listening out there, thank you, because I've been here for 15 months now, and I've never seen anything in my life like the donors in this community.
Yeah,
and it is really remarkable what has happened in the 15 months since I've been here. So just to start with, all of our mammography machines have just been replaced with new state-of-the-art mammography equipment.
Really?
We had 5 units previously total, 4 here at Lucy Curci and then 1 out at Argyros in La Quinta. And we replaced the 5 units with 6 units, 4 here and 2 out there now. So all of those are state-of-the-art mammography equipment, and is really remarkable on the part of our donors to have provided the funding for that. As part of that, we got, Dr. Elmi talked about the CESM, but on one of our units, we now have new state-of-the-art contrast enhanced mammography. That's part of one of those units. In addition, donor funds are paying for a new ultrasound unit that is going to go out at La Quinta, and is going to allow us to start that. And the second mammography machine out there is going to allow us to start seeing diagnostic patients out there. Up until now, we've just been doing screening mammograms at Argyros. But starting soon, hopefully by December, we're going to be able to do diagnostic mammograms and ultrasounds there as well. So that's as a result of having the new equipment. Another piece of new equipment, 2 pieces, are new DEXA units for bone densitometry. I'm going to let Danielle say a few words about what they do and the difference between them and the old units.
So currently the units that we have just screen for osteoporosis, the standard, you know, osteoporosis, the standard scan. But with the new units that we're going to be getting, we'll be able to actually do pediatric scanning. We'll be able to do some vertebral assessment for those patients that are at high risk for fracture. And these units will also be able to do body composition. So everybody wants to know what their body fat percentage is now. So, you know, we'll be able to tell you what that is as well. And then another interesting fact with the new equipment is that once we get it installed, the patients will have a quicker access to the results via MyChart. So right now, technology doesn't allow that, but when we get this equipment in, it'll be quicker and more available to patients and physicians.
That's fantastic. That's fantastic. Anything else we need to look forward to? Or?
Yes, we're not done yet. So in addition, so we currently, up until now, we've had what's called a prone stereotactic biopsy table. So for women who needed a biopsy guided by the mammogram, it's a stereotactic biopsy. It's done with the woman lying down on her stomach. And that can be a challenge for certain patients. Certain patients can't lie on their stomachs for one reason or the other. The table can be uncomfortable because your head has to be turned to the side. So for women with significant arthritis in the cervical spine, it can be a real challenge. Our donors have provided us with yet another benefit, which is now an upright stereotactic biopsy table. So we now have the choice to do patients lying prone or to be able to do those biopsies with the woman sitting upright. So it's really a remarkable ability to be able to have a choice for how we could. So we used to have to occasionally send women away because they couldn't have the biopsy lying down, and we had to send them to a place where it could be done upright. We can now do that ourselves. One other thing that I want to talk about is that needle localizations here, which is a procedure that's done prior to a surgery for a lesion that the surgeon can't feel. The radiologist has to guide the surgeon to that lesion in the breast. And up until now, that's been done with what's called conventional wire localization, where on the morning of surgery, we place it's a needle with a wire that goes through the needle, and the wire is put in place in the breast. The woman, may be coming here for a surgery that she's going to have at 2 o'clock in the afternoon, but this may have to be done at 8 o'clock in the morning. And so she's sitting here all day waiting. We now have a new technique that's called wireless localization with something called the Savvy Scout that we're using. And this allows us to very accurately place this wireless device. It's like a little tiny antenna that's placed into the area of concern in the breast. It can be put in a month before surgery or a week before, it doesn't matter when. And it's in there. And then on the day of surgery, the surgeon uses a little wand that's essentially, it's an infrared detector. There's no radiation involved, but this little antenna emits a loud signal that you can hear with this wand and allows the surgeon to, with pinpoint accuracy, find that area of concern, find the tumor. The data has shown that the specimens that are, the lumpectomy specimens that are removed are smaller as a result of this, and the number of re-excisions is less with using that compared with conventional wire localization.
That's remarkable. That truly is quite an exciting advancement.
And then the final thing I'm going to talk about, there's more yet. So I just wanted to talk, I'm not going to talk about it. I'm going to have Dr. Elmi talk about it, but this is going to be the new high-risk clinic that we are going to be establishing here. So
high-risk breast clinic.
Yes.
Oh, okay. Tell us, Dax.
So first off, starting with what is high risk. So we have most of our women and men are called average risk, meaning that they have that lifetime risk for breast cancer about like 7 or 8% in their life. Then we have high risk, which means they have the lifetime risk of developing breast cancer about 20% or higher during their lifetime. So what can cause a woman move from that average risk to that high risk? Are multiple things, but most important one would be the genetic predisposition. Women with multiple family history of breast cancer or breast cancer in a male in their family, or at early age in multiple, women in their family, ovarian cancer and breast cancer in the family. So these are, gonna bring up the risk for the patient.
That's that. Excuse me for interrupting, but that's that BRCA, that BRCA 1 or 2 gene.
That's one of
Angelina
the genes.
Jolie went public about.
Yeah,
right?
there are multiple genes, but the most well-known gene is the BRCA gene.
You.
And then patient with prior radiation to their chest, there are multiple factors that can predispose a patient to breast cancer. So this is going to be high risk. So when a patient is considered to be high risk, higher than average, they need to be assessed. So it's not like there is not possible for their primary care doctor or GYN just off the bat to be able to tell if they're high risk or not. So when the patient has some family history, some stuff more than average, so they would be referred to something we call it high risk clinic. And what usually high risk clinic is, usually they have a breast surgeon or a nurse practitioner or PA associated with a breast surgeon in charge, and they would have a genetic consultant person who would be, working with them just to determine if a patient is high risk or not. So the patient goes in, all the family history, all the history will be taken, all the prior breast history, all the pathology they have will be taken, and then they would plug them in different risk model, and then they would calculate it, and they can tell what's the risk, lifetime risk for that woman to develop breast cancer. And if it meets a certain number, they would plug the patient into certain personalized kind of a screening program for their lifetime.
What a fabulous program to be offering to our community once again to take care of their health and well-being. That's exciting. We'll look forward to more information as we go down the road on that. So if you haven't been impressed before now of this incredible team and what we offer at the Lucy Curci Cancer Center, Schnizter Novack Breast Center, I think you've heard quite a bit. I certainly am, and I mean that quite sincerely. I am delighted to be a patient of that center. So I think we have some time for questions. Is that okay with all of you? Let's see what we have up there. Yes, right, we're good? Okay, so any news on freezing tumors like they do in Israel? Oh, that's a great question. I read about that. Sure, anyone?
You want me to jump in? So this is called ablation of tumor. It has been used over several years for other kind of tumor, especially for kidney tumor, prostate tumors, liver, and lung tumors.
Ablation?
Ablation, yes. So you can use either ice, it's like minus 96-degree temperature, or heat to ablate the tumor. In the past 10 years, it's being used for breast in research for now. So they are all in clinical trial. There's no FDA approval for any of the devices so far. So I was at Memorial Sloan Kettering for my fellowship. We actually offered that technique for a patient, but it was part of a research protocol. It was part of a clinical trial. So we are working on it. We are still waiting on the data to show solid benefit for our patient population. As soon as we are comfortable with that data, we're going to just, start looking for the devices and start the process.
That's wonderful. That's exciting news. Thank you. What else? And I apologize, Brett. It's a little bit cut off on that first word, but it's something afternoon.
Good afternoon.
Good afternoon.
Good afternoon. Oh, sorry about that. I should have got that. Good afternoon. I was wondering, in what circumstances would a 3T MRI used versus a normal 1.5T?
I'll answer that. So, basically, they provide the same information, and the 3T, as Dr. Saponaro mentioned earlier, is a higher resolution scan. So basically, we currently are doing our scans on 1.5 Tesla. They're perfectly good scans. Not all places are using 3 Tesla, but when we have the 3T magnet, and should be within a few months now, our plan is to do all of the routine diagnostic breast MRIs on the 3T magnet. Yeah.
Wonderful.
I might point out that certain people won't qualify for the 3T,
Right.
because of restrictions like a pacemaker.
Right.
However,
an MRI.
Our new 1.5T MRI will allow patients with pacemakers to be scanned. So there will be virtually nobody that will be excluded with the combination of scanners that we will have available to us
I didn't know that.
sometime next year.
That's good to know. Thanks, Dr. Saponaro. And for those of you listening, whether it's men or women with men in your lives, please note that 3T MRI will be very useful in prostate cancer screening as well. So that's very exciting. Thank you for letting us know that. Okay, let's go on to that next question. Would you or can you please explain, oh, this is a very good question. Will you please explain what it means when a mammography shows an asymmetry in a breast? Great question. We hear that term a lot. There's an asymmetry. Please.
Well, Dr. Sylvan should handle this one. This is a very difficult topic.
So asymmetry is really just referring to when we look at the breasts, the two breasts side by side, usually they look fairly symmetric. And when we see an area that stands out and looks a little different on one side versus the other, it doesn't form quite a discrete mass, but there's something about the tissue that looks different from the other side and different from the surrounding tissue in the breast. We refer to that as an area of asymmetry.
Oh.
It's just an area that, without being a discrete mass, looks stands out, and something about it looks different enough from the rest of the tissue to make us want to investigate it further.
Makes sense.
And sometimes compression can really help with that. It can avoid having to come back for asymmetries that are not real. So compression really does separate that breast tissue to get the radiologist the best picture possible, for that mammogram.
Okay, so just because compression is uncomfortable, now we have another reason not to skip those mammograms. I have a question for all of you. What is the difference? I've heard the term now a few times, between a diagnostic mammogram and other mammogram. What's the difference? Anyone?
So the two types are a screening mammogram, which you have standard views that you can run an entire population through, and it's designed for cancer detection. And a diagnostic mammogram is when that screening mammogram shows an abnormality or a potential abnormality, and then you come back and have a focused examination on that area of question. So we get to use all of our armamentarium to try to figure it out. If we could stick you in an MRI the same day, that would be the ultimate diagnostic test, but sometimes we can't. But yet generally it includes additional views and ultrasound to try and solve the problem.
And I think, Allie, too, that some women think that a diagnostic mammogram is better, that it's more detailed.
Right.
When in reality as well, the screening images that we take are the same as the diagnostic images. So if you're coming for your annual screening mammogram or your annual diagnostic mammogram and you're not having any other problems, you get the same screening pictures as the diagnostic pictures. So one does not have a better quality over the other. The diagnostic is more if you're problematic and you're having problems with the breast, or there's a lump, or we're following you for breast cancer as well. So I think some women think just because they're a diagnostic that they're getting a better picture, but you're getting just as good quality pictures on a screening exam, as you would on a diagnostic exam as well.
That's really helpful. I facilitate our breast information and support group. Again, a shameless plug, but for those of you who have been diagnosed with breast cancer, please think about joining us. That would be so helpful to you, we think. Here we have some more questions. Thanks, Brett. Is there a risk of breaking tumors or otherwise spreading cancerous cells from the compression of a mammogram?
There's absolutely no evidence whatsoever that that's the case.
There you go. Direct answer, very clear,
Allie,
very specific.
I would add to that we often get the question, if I get a biopsy, will it spread my cancer? And the answer is no, not with this type of cancer.
And what about for women who have implants? Thank you, Dr. Saponaro, too. What about women with implants? Is there a danger of rupturing or harming that implant with mammogram?
No, we do tons of women with implants every day. And we never compress the implant. I think there's a misconception again that implant is compressed with compression, But when we take a picture of the breast with the implant in place, it's looking at the integrity of the implant. We compress the tissue in front of the implant, not the actual implant itself.
Wonderful, thank you. We have one more question up there. We are getting towards our end, are we not? Fred, so yeah, so if you have a question, get it in quickly. Let's see what Lisa is asking us. When they say a patient with ovarian cancer make them at higher risk patient. I'm assuming you mean for higher risk for breast cancer. And why is that? Dr. Elmi?
So as I just said earlier, breast cancer and ovarian cancer can share some common genes. So if someone has ovarian cancer, might have some of those genetic mutation that would predispose them for breast cancer. But again, having ovarian cancer alone is not going to put you at higher risk. So again, if you have that kind of history, you can talk to your doctor, your GYN, your primary, and if needed, they can plug you in with one of the high-risk clinic, and they will take it from there, and they will look into your genetic and your other factors to see if you're high risk or you're just an average risk person.
Excellent. We're going to end on a question. Anne, I'm so pleased you asked this question. This has been an ongoing thorn in the side of breast centers and radiologists, breast radiologists for years. Very quickly, doctors, before we say our goodbyes, would one of you please address thermography or thermage as a way to detect a cancer sooner in the breast?
It's not useful.
Thank you.
So, that's the bottom line. It's not useful.
Exactly.
People have been trying for years and years and years to show that you can use temperature to, yeah, I mean, sure, if you have a large cancer in the breast and you do a thermogram, you might see some heat in that area of the large cancer. Its ability to detect the cancer sooner, absolutely not. It's not detecting cancer sooner. It's really a disservice to women to offer that.
Yes.
Yeah, exactly. As a reminder, I want to remind our women, we are using a screening. The goal is to detect the cancer as early as a stage possible. At the point that we can treat it, we can cure it, not let it grow to the point that a thermography can detect it. So just keep that in mind.
Thank you for that. We do want to remind you, especially during this time of COVID, this last year and a half, almost 2 years we're coming on now, that many people have put off their screenings. We urge you not to do that. We urge you as medical professionals to get vaccinated. We urge you to stay on top of your screenings for your health, for yourself, and for those that love you. I want to take this opportunity to thank you all. I know how busy you are. This has been so helpful and informative and enjoyable. So thank you very much for your time. Thank all of you very much, and we look forward to seeing you again very soon. Thank you.
Okay.